everyone. I would like to thank TCT Asia for this opportunity given for presenting my interesting case. So my case is on retrograde LAD CTO recanalization via bypass graft. Now, this is the rarity of this case is the fact that the retrograde approach was done through a bypass graft. So the clinical scenario, it's a 70-year-old male, diabetic and hypertensive, who had a prior CABG in the year of 2000. He had a Lima to LAD, SVG to OM, and RPD at that point of time. He now presented with effort angina for 1 year duration. On examination, nothing remarkable. Investigations showed a normal hemogram and a creat. ECG was normal sinus rhythm. Echo is normal LV function. Chest X-ray is within normal limits. This was a diagnostic left side angiogram done from the femoral lute, which shows a minor osteal disease of the left main, followed by a bifurcation. LAD is flush occluded, as you can see from here. It's completely occluded at this point with a flat, almost a blunt kind of stump. And we know that this has been occluded for past 17 years because the angiogram before the CABG also mentions the same thing. So this is a blunt stump with a JCTO score of 3, and the LCX also is proximally occluded, but you can see there is a rapid runoff of the diaphragm at this point, suggesting that the SVG to OM is patent. And now looking at the RCA pictures, this is RCA is proximally occluded. What you see here, RCA probably goes down this way. It's a flush occluded after this point. What you're seeing is a large conus kind of branch, which has a or a RV branch, so to say, which has a proximal stenosis, and subsequently that actually gives some epicardial collaterals to the distal LAD. So distal LAD seems to be filling quite well from this collaterals, which suggests that there is some issue with the Lima, and the Lima probably is not flowing well. Now, this is the SVG to PDA graft, which is actually flowing quite well, and that again gives some amount of collaterals to the LAD, but the filling is not very well seen. And this is a Lima injection, which actually shows a very tortuous Lima, almost 2 S-shaped bends. And after the anastomotic point, there's absolutely no filling of the LAD. What you're seeing is some amount of diagonal, which is the filling is seen. Now, clearly, this patient now has a rare scenario where you have an occluded arterial graft, Lima is occluded, and the venous grafts remain patent. Usually, it's a vice versa, and this is around 17 years down the line that has happened. Probably, maybe because of progression of atherosclerotic disease at the anastomotic point. We were not sure exactly why it has happened, but he's got angina, which is refractory to medications, which warrants that he needs a angioplasty to the LAD or recanalization of the LAD at the earliest. Now, what are the interventional options for LAD recanalization? One is we can go through this native RCA, RV branch, and through the collaterals into the LAD retrograde. But the issue here right now is the fact that there is a proximal stenosis here. It's a smallish vessel. It's a tortuous epicardial collateral, so the risk of rupture, bleed, effusion, everything is high. So, and the support also may be an issue. Next one is to go antegradely through the blunt stump of the Lima and try probing here. But again, here you're not certain as to which direction the LAD will fill. And even if you get through, you'll probably be supplying only the very distal LAD and nothing about the proximal and middle LAD, and the other diagonal septals will remain occluded. The third option is to go through the SVG to PDA. As you can see, the PDA gives a lot of transseptal collaterals. For example, this one particular collateral, transseptal collateral, looks very promising in terms of size. And of course, the obvious one, which is the antegrade approach through the left main into LAD, I didn't mention it because that's one option we can try. But as I mentioned, the JCTO score is high, and the chance of getting through that is on the lower side. Literature for retrograde CTOs through bypass grafts are extremely rare, associated with higher complication of graft thrombosis, pericardial effusion, slow flow in the graft, and sometimes graft perforation. Success rates are comparable since the grafts are big vessels. There are reports of native vessel recanalization through an acutely occluded graft, but that's a ACA scenario, not applicable for our case. And a lot of advanced skill and understanding of hardware is important in this particular case. We went with a bilateral femoral approach. There's a donor guide, which was a 6 French MPA, which was intubated into the SVG to PDA. Recipient guide in the left side, left main, left coronary was 7F XB LAD 3.5. And as would be expected, before going retrograde, we always give an attempt at antegrade with Gaia 2 and Miracle 6, which obviously was unsuccessful, probably because of the calcium present there and also the blunt occlusion. And then we decided to go for the SVG to RPDA collateral. And as you can see here through the multipurpose guide, microcatheter, this is actually the scion wire which is crossing into that large transeptal collateral. And once the wire crossed, we got the fine cross microcatheter up into somewhere around the mid-LAD segment. And after the mid-LAD segment, we had made multiple attempts of going through the distal cap with the Gaia 2 and Miracle 6, but again failed. And at some point, we actually thought that we may not succeed. And that's when we decided we'll again try with a usual fielder wire, and actually the scion wire itself, this wire actually got through the distal cap, went through the proximal cap, and into the left main. So this is probably some sort of microchannel which has opened up because of constant probing from both the sides using stiffer wires, and the wire actually can be seen going straight into the recipient guider. And then once that was done, we changed to an RG3 wire. And once the RG3 wire was in place, we did an anti-grade POBA using a 1.5 initially, and then a 2 mm balloon. And please remember that this wire actually goes through this particular septal here. So we cannot dilate beyond this point. So we did a dilatation till the point the RG3 reaches the septals. And once we did that, this was the angiogram, which shows a diffusely diseased LAD. And this is the septal we came through. And this was the distal LAD filling, which is seen. And you can see the diffuse disease probably explaining why the Lima graft got occluded. And so we pulled back, we did a wiring of this using, leaving the RG3 here. We put a parallel scion wire into the distal vessel. And this shows the distal scion going into the true lumen. And the antigrade wire crossing is seen. And once we dilated, we did an IVUS, which showed actually almost a 360-degree calcium arc can be seen, which was dilated using NC balloon, and some cutting balloon also was used to dilate this. Once that was done, we had to stent the whole segment from the left main to the mid-distal junction using sequential stents 2538, 338, and a 4x18 for the left main to LAD. Now the stents were correspondingly sized, post-dilatations were done, and the stents yielded. There's a very good result. Only thing, there's paucity of some diagonal flow in the other side, but otherwise the flow down the LAD and the left main is very good. And this is the caudal view, and this is the cranial view that is seen. Once this was done, adequate, as I mentioned, adequate post-dilatation, everything was done, and then we did a IVUS run. Sorry, I think I missed that. Yeah. So this is the IVUS slide. The IVUS shows actually that the lumen is very well expanded, very well stent opposition. Distal LAD is 5, middle LAD is 6 square millimeters, proximal LAD of 8.5, and left main is 13 millimeter square. So suggesting that the stents are very well expanded and very well opposed. There seems to be no malopposition, and the result was very good. Clinical follow-up, the patient was doing well after 2 years of procedure. He had no angina, and he was reasonably free of his symptoms at the end of follow-up. Thank you for your patient listening.
Yes. Yes. Any comments from anyone? Any experts? Any comments? Very good case.
So, what is the rate of improvement? What is the rate of improvement of TINI flow with vasodilatory cocktail? Is it always better to give through perforated balloons or through a microcatheter? It's always better to give through a microcatheter or a perforated balloon or even an aspiration catheter. Previously, we had catheters called the clear. I think it is still available. The clearway catheters, where you can go distally and give the drugs quite distally, but the response, measurement of response, it is something like what do you call it? Is it's a test trial. It's something like a trial. You give, most of us give most of the drugs available when there is a real slow flow. We give sodium nitroprusside, we give nicorandil. The only thing is that available data of nicorandil says you have to give it 6 milligram, then followed by, if needed, you can give a IV continuous. I give continuous for next 24 hours. Then adenosine, it's pretty high dose of adenosine used in the studies. 3 to 6 milligram was the median dose of adenosine used. So we have to give pretty high dose of these vasodilatory agents. The 3 drugs which I have found quite useful are adenosine, this particular higher dose of adenosine, nicorandil, and sodium nitroprusside. Then the response, it is very difficult to judge the it is quite difficult to predict the response. Bang sir, what do you think?
I think when vasodilators don't work for some reason, what do? That is when the real challenge is. And adrenaline,
intracoronary
adrenaline is something very effective. I have experienced personally. Very effective.
How much do you give?
It's very small doses. We dilute in 1 ml in 10 ml. First we dilute that, and then take 1 ml and then again dilute by 10 ml and very slowly and we are try to see the response, how the response is, because otherwise blood pressure goes up very high. suddenly. So you have to, and heart rate goes very high. So you have to be very carefully titrate the dose of adrenaline enough to give the response. So slowly, but it's like, you are holding a syringe in the hand and trying to slowly give and looking at the response. So, but I found it amazingly good. Amazingly good. Because earlier, if I remember right, before ticagrelor, the no flow situation was very bad situation for acute MI before ticagrelor. And we used to get stuck what to do now. I mean, I remember one police commissioner was admitted under me with acute MI, anteroceptor. Everybody was there. So many people came to visit him, naturally. Police commissioner of Mumbai, way back in 1995, I'm talking. So I opened the artery, LAD, huge, large thrombus burden in the proximal LAD, and no flow, and tremendous angina, very much angina. And finally, we could get away only by adrenaline.
And I think adrenaline, I have seen many of the senior and experienced operators telling.
But you have to titrate the dose very well.
Though it's not mentioned in the textbooks or guidelines.
No, it's mentioned. It's mentioned. Now it is in the literature also.
So I think that's a good option. And always anticipate slow flow, no reflow, and prime the vessel with the vasodilator.